Hello everyone. I'm glad you could join me for our first 15-minute webinar of 2018, SIRS, Sepsis, and Severe Sepsis. My goal for today is to define sepsis and the clinical criteria that's evolved over the years so that those attending have a better understanding of where we are today with sepsis and the challenges coders face. As always, a reminder that the educational materials such as this presentation and its contents are protected by copyright law. These slides may not be revised or redistributed without express permission of iMedX. Per the Center for Disease Control and Prevention, or the CDC, sepsis is defined as the body's extreme response to an infection. It is life-threatening, and without timely treatment, sepsis can rapidly cause tissue damage, organ failure, and death. Clinical criteria for diagnosing sepsis were first proposed in 1991 and updated in 2001. The third International Consensus definitions for sepsis and septic shock, or Sepsis 3 criteria, were developed in 2016. Using electronic health data, the Sepsis 3 criteria were developed using sepsis criteria plus patient outcomes, in other words, mortality. Sepsis 1 was developed at the 1991 Consensus Conference, in which 4 SIRS criteria were defined and established: tachycardia, tachypnea, fever or hypothermia, and leukocytosis, leukopenia, or bandemia. Patients who met 2 or more of these criteria met the definition of SIRS. Many coders who are familiar with ICD-9-CM will recall the SIRS criteria set forth to define sepsis. Using Sepsis 1 criteria, sepsis was defined as infection or suspected infection that led to the onset of SIRS. Sepsis complicated by organ dysfunction was termed severe sepsis. Severe sepsis could then progress to septic shock, defined as sepsis-induced hypotension that persisted despite adequate fluid resuscitation. The 2001 task force recognized the limitations with Sepsis 1 definitions, and while they did not offer alternatives due to a lack of supporting evidence, they did expand the list of diagnostic criteria to include 21 bedside or laboratory tests, resulting in the introduction of Sepsis 2. As with Sepsis 1, in order to be diagnosed with sepsis under the Sepsis 2 definition, an individual must have at least 2 SIRS criteria and a confirmed or suspected infection. At the 2001 conference, a hypothetical model for staging sepsis, recognized by the acronym PIRO or PIRO, was presented. The PIRO model proposed future research on staging sepsis by classifying patients on the basis of their predisposing factors and premorbid conditions, the nature and extent of the underlying infection, the characteristics of the host response, and the extent of the resultant organ dysfunction. The definitions of sepsis and septic shock remained unchanged. If we view this from a coding perspective and apply the terms using the definitions for Sepsis 1 and Sepsis 2, it is easy to see that ICD-10-CM has equivalent codes for sepsis or SIRS due to an infection, severe sepsis, and septic shock. Therefore, challenges continued with diagnosing this life-threatening complication. Thus, a task force was created to re-examine the definitions for sepsis and septic shock. As a result, the 2016 task force proposed a new definition of sepsis, termed Sepsis 3. The new definition abandoned use of the Host Inflammatory Response Syndrome criteria, or SIRS, in identification of sepsis and eliminated the term severe sepsis. Recommendations offered from the 19 physician members of the task force included the definitions shown on this slide. Per Sepsis 3 criteria, sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. In addition, Sepsis 3 defines septic shock as a subset of sepsis, in which profound circulatory, cellular, and metabolic abnormalities increase mortality risk. This slide lists the key findings documented by the 2016 task force. Since there are multiple definitions and terminologies currently in use for sepsis, septic shock, and organ dysfunction, they determined that this led to discrepancies in reported incidence and observed mortality. Under the old definition, if a patient presented with 2 SIRS abnormalities due to infection, this was classified as sepsis. The challenge here is that other conditions can also cause SIRS, thus making physicians reluctant to call SIRS-positive cases sepsis. SIRS supports evidence of an infection, yet does not always support a diagnosis of sepsis. As part of the 2016 evaluation of criteria for identifying septic patients, the task force compared traditional SIRS criteria to other methods. Based on this analysis, use of sequential organ failure assessment scoring to assess the severity of organ dysfunction in a potentially septic patient was recommended. The sequential organ failure assessment, recognized by the acronym SOFA, is used to determine the extent of a person's organ function or rate of failure during their ICU stay. The scores from criteria results for 6 body systems are then used to predict outcomes and estimate the risk of morbidity and mortality due to sepsis. This slide illustrates the actual sequential organ failure assessment, or SOFA, scoring system. Each of the 6 organ systems is assessed by the designated measurement and assigned a score based on the data obtained. Recognizing the practical limitations to the timely assessment of all 6 body systems using the criteria set for the 6 organs, the 2016 task force described a simplified method termed Quick SOFA. The Quick SOFA, or Q-SOFA score, is a modified version of the SOFA score. The quick assessment of the 3 body systems, respiratory, neurological, and cardiovascular, provides an easier way to identify patients who have a higher risk of mortality or death from sepsis. As you can see in the table, each of the 3 components, when met, equates to 1 point. A Q-SOFA score of equal to or greater than 2 points indicates organ dysfunction. So if we revisit this slide again, I think you are able to see the current challenge that coders and CDI staff face, depending on what criteria physicians use to document sepsis. If we use Sepsis 2 criteria, we have 3 categories: sepsis, severe sepsis, and septic shock. Per Sepsis 3 criteria, there are 2, sepsis and septic shock. Using the Sepsis 3 definitions, the term for severe sepsis has been eliminated. So if physicians are using Sepsis 3 criteria, their documentation of sepsis may indeed equate to the ICD-10-CM code for severe sepsis if organ dysfunction related to sepsis is documented. The table on this slide shows the new clinical criteria for sepsis and septic shock under the Sepsis 3 criteria. With these new definitions, when a patient meets criteria for sepsis, there will be more accuracy for cases of sepsis without false positives. You'll recall from earlier in our discussion, ICD-10-CM coding is based upon the Sepsis 2 definitions and not the Sepsis 3 definitions. With the Sepsis 2 definitions, there are codes that represent sepsis based on SIRS criteria and severe sepsis for organ dysfunction. For example, per the new definition for Sepsis 3, a physician's diagnosis of sepsis will correspond with the old definition's diagnosis of severe sepsis. We've only scratched the surface within this 15-minute webinar with providing critical information on this topic. Are you interested in learning more about the impact the change in clinical criteria for sepsis has on the coding professional? Join us for an in-depth discussion in our 1-hour webinar, SIRS, Sepsis, and Severe Sepsis, Let's Get Those Questions Answered, where we'll discuss the challenges that impact the accurate coding of SIRS, Sepsis, and Severe Sepsis, and the role physician queries and facility-specific guidelines play in facilitating the proper coding of these cases. Specific ICD-10-CM official coding guidelines pertinent to sepsis coding will be reviewed and scenarios will be provided in order for you to learn how to interpret and apply these guidelines. We will further discuss what impact the updated criteria have on coders, since many questions remain regarding assignment of codes based on physician documentation versus clinical documentation based on the Sepsis 3 guidelines. As an added bonus, support from our coding experts is available to answer any additional questions you may have after viewing the webinar. To purchase the full comprehensive webinar, click on the first link in the video description below. The full webinar has been approved for 2 AHIMA CEUs. Please let us take a moment to let you know a little bit about some other iMedX education opportunities. iMedX believes in a humanology, that's humans plus technology, approach to health information management. Bringing together innovative technology and unparalleled experience to give our clients a significant edge in clinical documentation is our goal. Our education team is comprised of experienced education consultants. Our consultants have trained over 1,000 coders in ICD-10 and serve as our expert resource for our own coders and consultants. Our team is flexible and can provide live custom training to fit your facility's needs. We also offer at-your-own-pace training through iMedX University, which is our online learning management system that combines interactive multimedia with a vast array of course and content options to cover any student's needs. You are also experiencing a brief overview of one of the trainings that we offer, which is coding webinars. Some of the trainings that we provide are other one-hour webinars, advanced training for PCS, ICD-10-CM, ICD-10-PCS, and CPT training. Training Code, which is a program that offers one-on-one mentoring to train beginning coders or enhance coding performance of existing coders. Intermediate ICD-10 workshops, custom education development for organizations, and we are also in the process of developing a clinical documentation improvement program. To learn more about these education opportunities, please visit our website at imedx.com/edu or simply click on the link in the description below. Our education team at iMedX would like to thank you for providing us with the opportunity to share some of our knowledge with you today during this 15-minute webinar. We hope you can join us next month for our next Focus 15 webinar entitled Calendar Year 2018 OPPS Changes.